I'm Dr. Antonio Chirumbolo. I'm excited to be here with Dr. Patricia Fulmer, Dr. Dan Epshtein. We're going to be talking about ultra-wide field imaging, and in particular the CLARUS 500. You guys both use it in your practices, correct? Yeah. So why don't you just take a minute to introduce yourselves?
I'm Dr. Patricia Fulmer, practice out of Huntsville, Alabama. I started my career in a secondary tertiary medical referral center, did only medical, and then recently last year got back into private practice, and that's where we incorporated the CLARUS. We got it in December of last year, so we've had it about 4 months. First practice in our state to get it, and we've loved it ever since.
I'm Dr. Dan Epshtein. I work here in New York City. I'm in a multi-specialty ophthalmology practice. Really high volume. We have patients referred to us for surgical procedures. We have patients referred to us just for things like glaucoma evaluations. And we do, as far as optometry, we do a lot of non-surgical care, and anything really doesn't need an injection or surgery, it falls on me. So we're doing a lot of glaucoma. We're seeing a lot of diabetic retinopathy, which doesn't need to be treated. And we've been using CLARUS quite a bit. It's actually become sort of my standard for fundus photography now.
Yeah, so, I think we should really start from the top here because, fundus photography has been around for a long time, but this is a little different, right? It's ultra-wide field imaging. I mean, what does that term mean, ultra-wide field imaging?
So I think the accepted terms now in the literature is that wide field is going to be about 100 degrees, and ultra-wide field is about 200 degrees. When you talk about standard fundus photography, that's about 45 to 60 degrees. So you're really getting quite a bit more retinal surface area there. There's been instruments in the past that have done ultra-wide field, but CLARUS, just in my mind, is sort of the newer generation. It has a lot of new features. The optics on it work a little bit different, so you're getting more true color images, you're getting less distortion, looking both at the posterior pole in high quality and the periphery in high quality, which your previous systems, you weren't able to do that. A lot of people ended up having an ultra-wide field camera, and then they had a standard photography camera, which right now, with the system, we don't need.
Yeah, I think an easy way to think of that is your standard photography got your posterior pole, got your nerve, your macula, your vessels. Wide field got you a little further, mid-periphery, maybe start of some periphery, and then your ultra-wide field gets basically everything. You're able to capture side to side, 200 degrees, in a way that we've never been able to do it before, where it's not distorted. The colors are true from nerve to periphery, both in lesions and in normal maculas and vessels. You're able to zoom in to a level where the vessels feel like they're popping out at you, and you don't lose any quality no matter what you do to zoom in, zoom out, change the photo for interpretation purposes.
So these systems have been around then, right? But this is a little different. Okay, so what are some of the shortcomings of the other systems? You kind of briefly just touched on this in the past that are now different with the CLARUS.
I think color is your number one most obvious,
and
you don't get the bowl effect that we got with some of the others. Before, when you looked at an ultra-wide field image, I think everybody kind of got that inward bowl effect, and the nerve was very tiny, and when you zoomed in, you didn't keep the quality. And now it's a very easily interpreted flat image where everything is still in focus, and you're getting true color. And in my opinion, true color is probably the most important change, because without the true color, you cannot diagnose and interpret and follow a patient in the same level.
And true color is exactly what you're saying it is, right? True color.
Absolutely.
What you're seeing.
True color. It's what I see when I do a BIO or a fundus exam, is what I see on the camera.
Yeah. Why is that so important, though, to have true color?
So true color is important for a few reasons. One, when you have true color, everyone knows what you mean by when you're actually looking at the image. It's what we all learned in school when you look at the retina and soot lamp or with BIO. If you have false colors, that's another level of interpretation. So especially in a practice like mine, where at any given day we have 4 or 5 doctors, if that patient's seeing different doctors for the same issue, if you put a second level interpretation on that, that's going to change patient management.
Absolutely.
So here, there's much less interpretation variability between doctor, and of course that means less differences for the patient, and overall outcomes are just much better.
Yeah, especially peripheral things, retinoschisis versus white without pressure versus, is it a detachment? Being able to really see those color changes in the same way that we would on a BIO scan gives you that other element of interpretation that you wouldn't have had before.
Yeah, I think the peripheral pathology has been a huge thing, because when you had false colors, you always see these things like, these on Facebook, someone will post up a picture, is this a detachment, is it a schisis? and then 1,000 people say, and you have 1,000 different answers. So when it's true color, you have a much better idea of what's going on, because again, you don't have to interpret it.
Yeah, what kind of disease processes is ultra-wide field imaging really beneficial in? I mean, or is it really for everything?
Would it be too cliche to say all of them?
All of the above, right?
Yeah, no, I think you absolutely hit it on the head. Peripheral pathology, nevi, because you can do filters, AMD for both the FAF and the zoom capabilities, the glaucoma, because you're repeatable, you can do everything right there, quickly, easily, compare the images, document, I mean, truly
so it's
everything.
even good for the optic nerve then, is what you're saying, right?
Absolutely.
Yeah, and then the other thing with this system, it's not just posterior pole and retinal pathology. You can also take anterior segment images as well, which is completely new to the ultra-wide field game as far as I know. And again, it's not like a slit lamp where you're taking images in optic section, but you really get great images, particularly in patients with sort of lid disease, like lid margin disease, or patients who are scenic with their iris, so you can really get a good image so I can see, oh, did it break on follow-up, or has it changed at all? It's really helped me a lot there as well.
Let's talk about specific disease states maybe, and let's start with glaucoma, because you both manage a lot of glaucoma in your practices, right? So, how are you using Clarus in the treatment and management of glaucoma?
Just me personally, the way I always take a photo of every glaucoma suspect, every glaucoma patient. Fundus photography is really helpful in that. So for all my glaucoma patients, on their first visit, I usually dilate them. Like, oh, you have large cupping or asymmetric cupping, whatever it might be, go get a photo. And then I bring it back for their glaucoma workup, which is OCT, visual field, PACS, all that good stuff.
Yeah, beyond that, for me, it's the ability to zoom in on this camera without losing any kind of quality of the nerve. When you first take it, the nerve looks very small, but you zoom in and it becomes as good or better than a 45-degree regular fundus image. There's also a feature on the camera where you can do a stereo image. It's 2 side-by-side pictures, very, very easy for the technician to take the pictures, and then it's just merging that into one on your own, or if you need, there's a lot of stereo glasses and things like that that you can use with it, but it's a feature that I think gets left behind sometimes. It was used a lot in the past, but it's nice to have a new technology with that.
I also think it's important, and we'll talk about some other different retinal pathologies that you treat and manage, but I think it's important too to note that you work in a very heavy disease-based practice, right? But you don't need to work in a heavy disease-based practice to still enjoy some of the benefits of Clarus ultra-wide field imaging, right? Even just a general practice can do this, and you might not necessarily need to be treating and managing a heavy glaucoma patient base, right? Just what about general practice? I mean, how does this fit in?
For me, I think it's actually very, very integral for a general practice for 2 reasons. One, you're going to get your patients that come in and refuse to be dilated, right? Clarus has a really amazing feature of being able to get into a small pupil, and you can't do that with a standard fundus. 2 millimeters is typically what they say is kind of the smallest. I think we've actually gotten it on smaller. You may get a little bit of shadowing, but not in any way that you could complain about for having a 2 millimeter pupil. From a practice management standpoint, you can actually offer that as baseline imaging. It's interpreted differently than a fundus photo that would be built out in your practice, but you can do that as a practice builder. We charge $35 for a baseline image. We may do that for a lot of different reasons. Maybe the patient has a family history of something, but they're healthy and we talk to them, that's something we want to do. Maybe they can't or won't be dilated that day, and that's an option that we can do in lieu of dilation, still with patient education, of course. The other side of using this camera over any other is that you are able to get such, and we've said it before, but such good imaging all the way out. And so when you do other type of photography, if you're using just a standard fundus camera in regular practice, a lot of times, say I do BIO and I find a nevus in the periphery, to get that patient captured, they're looking far out, they're uncomfortable, they probably have to take a few different images, and that patient experience is not the best. And so in private practice, I think patient experience is huge, and this makes it much, much easier, much more smooth and enjoyable.
Yeah, so I agree. You don't have to be in a disease practice like mine. And in a general practice, you're still seeing the same pathology, maybe just not as often. So everything I do, any practitioner is going to do it. Maybe just I might do it 5 times a day, you might do it maybe once a day. But you still need the same documentation, you still need to follow up these patients. The management is the same no matter where you are. These patients, the disease doesn't really change, you know? Great thing that's been a help for me is, you know, we're in a very high volume practice, and the issue is always efficiency. You don't want to cut the quality, but you have to see a lot of patients. So the same way you have an autorefractor helps make your refraction more efficient, same thing with photography, especially ultra-wide field photography. I take a quick peek, look around, make sure there's nothing going on, and then I go do my DFE. Now, if there was some pathology, I could really highlight. I spend all my time on that. Well, sorry, not all my time, but a majority of my time on that. And I'm one of those people who thinks DFE and photography, ultra-wide field photography in particular, are just complementary. It's not one or the other for me, it's both, and it gives you a much higher quality exam in my mind.
Yeah, and I think it's interesting to be able to pull that up in the room and show the patient what you're seeing, because we've had numerous patients already, just in the 4 months that we're using it, that have never been dilated, or they refuse to let us, and we take the picture and we see something. They've got a tear, or you know, a chirpy or nevus or something that we didn't know was there because they've never let us look. And once we are able to show them that, then their whole perspective changes on their health. And so we can manage them better, they can manage themselves better.
Yeah, and I also know, Dan, that you're also using this just to manage other types of, you know, maybe what might seem like anterior segment disease, right? Like uveitis, you know, a uveitis patient comes in, but you're also utilizing this and that, right?
Yeah, so just the one patient comes off the top of my head. It was a patient came in very photophobic. He ended up having a very severe uveitis, and he was scenic. So he had a really small, sort of irregular pupil, and it was impossible to get DFE slit lamp on him. So I took him over to the Clarus, took 2 images, and he got 200 degrees right there. He actually ended up having a vasculitis, so it really changes the treatment for him. And if I wasn't able to look at a posterior pole, who knows what I would have done otherwise. So it really changed the course in that particular patient very drastically.
Probably would have missed it, right?
Probably, yeah.
Yeah, we kind of joke that Clarus picks up on some things. We told our technicians straight up, there's probably going to be some things on the camera that we notice on the photo that we may not have seen in the exam.
How long does it take to, you know, are you taking these images yourself? Are you training your staff to take these images? What's that like for, I mean, how hard is it to learn how to take the images? Is it a pretty simple process?
So in my practice, we basically have everything you can imagine. We have VPs, we have 2 OCTs, we have fundus camera. For us, the techs are used to taking images. We don't really take it ourselves. I'm probably the only doctor in the office who might take his own image because I want something in particular. But the techs actually said this was the easiest thing for them to train on. So they really like the slit lamp approach, and on the software, it really shows you how to line up the pupil very, very well. Whereas with other fundus cameras, a lot of times they have a hard time figuring it out because they don't know what a blurry nerve is versus a nerve which is in focus. So for them, it was very, very tough to train a lot of other instruments. I think for us, and within the first week, and again, we have a lot of techs. We have like 15 techs at any day.
That's a lot.
And we trained basically all of them in the first week, and they were taking pretty clear images. Yeah, so and plus with my patients who have cataracts, they're older, they're hard to get images on. If we could do it on them, I feel you could do it on anybody, basically.
We had, ZEISS was really great. They came in and did a training, and by the end of the training, which was, you know, only a few hours, our entire staff was very confident and comfortable with doing the photos. And to your point, there's 3 different screens that they monitor, so they can absolutely make sure that alignment is right where it needs to be before they take the picture. And then they, in addition, have a grayscale image of what they're taking before they take it. So it's super easy. We have some doctors that will take images depending on what's going on. You know, if they don't want their patient to wait and all of our technicians are tied up, they may run to the camera. But for the most part, it's our technicians 99.9% of the time.
Yeah. You know, how has this really helped you in managing macular degeneration? I mean, that's a big one, right? You see a lot of that, and you know, sometimes it's hard to distinguish. You know, you're looking at a macula, and you might say, you know, is that a drusen? What exactly is that? I mean, how have you been able to use the Clarus for that? Are there other features that you're using?
Definitely. They've got a FAF, a fluorescein, autofluorescence on there that is immeasurable, in my opinion, to what's been out before. We're able to take both a green filter if we want or a blue filter, but you've got both of those options in one camera. one filter. So the technicians simply click a button, the camera does its thing, they take the picture, and they're able to get that autofluorescence. And so that gives us another tool to be able to analyze that data. Between the detail and those extra layers that you get, you're really able to distinguish, is it a drusen, is it atrophy, is it which layer is it in, and use it to a different level.
Right.
Yeah, so autofluorescence is great. A lot of people will just do like an OCT, even on patients who have family history of AMD, you might not see any drusen, maybe some RPE changes, but autofluorescence gives us almost like a qualitative evaluation of the retina. So you might be able to pick up small changes or speckling. The big difference is you sort of got to figure out green versus blue. I think, especially for AMD, foveal disease, the green has been a lot more helpful for myself.
Same.
So that would be probably the best thing as far as, in addition to just regular photo documentation of the macula, is autofluorescence has been immeasurable. I think it's become more and more important as we realize ways that we can affect the course of age-related macular degeneration.
Yeah, I think we could take it a step further to nerve drusen, actually, because the blue filter, in contrast, picks up drusen in the nerve on a level that I don't think anything other than a B-scan has ever been able to do to date. So we've got a ton of patients that we've been following, maybe their nerve has a little elevation and we're not sure, is it something to worry about, is it drusen? And we've taken some blue autofluorescence images and they're right there. They show up, they glow, 100%. You don't need to worry about sending the patient out. It's a monitoring situation at that point. So to be able to provide that comfort to the patient, confidence in yourself, take that diagnostic step to really know what you're looking at, it's pretty impressive.
Yeah. When you see a patient, you might make an observation, you might document something, right? How is the documentation with this? I mean, can you talk a little bit about that?
Yeah, so documentation is just extremely easy. If you have any notes that you want to put on the actual image, you can annotate it right there. Let's say you have a choroidal nevus. I might remember how it looks like in my head, but if the patient comes back in 3-6 months, someone else sees this patient, if there's small changes, it's hard to really pick up unless you already saw that patient.
So would you say the images are pretty repeatable?
Yes,
Absolutely.
very.
That's one big inconsistency with other systems. You might take an image, you might capture something, and then you take another image a month later and you say, wow, this looks completely different, right?
Yeah.
Yeah, the illumination factor is actually pretty even from day to day. And the other issue is, especially if you have a peripheral nevus, it's not going to be distorted like it is with a lot of other systems. And like you were mentioning, it's very easy to get. You don't have to take 10 different images. You take one image and you get it.
Yep.
So in a group practice like mine, it's been immeasurable quite a bit. And the patient feels more at ease because they're like, oh, does it look like the picture from last time? And I'm like, oh yeah, it does. Whereas if you draw a little picture, like say, oh, one disc diameter, flat, no drusen, it could, if it grows by 10%, you're not going to notice it just from a drawing.
Makes it tougher for managing patients too, because oftentimes you might take a picture of an optic nerve and tell a patient you're managing for glaucoma or suspicion for glaucoma. You might say, well, we're examining your nerves and we're making sure there's no change over time. But if the images aren't repeatable, there could appear to be a change over time when there might not be, which can put you in a difficult situation. If that's a tool you're using
And Dan mentioned briefly the ability to annotate. It's really impressive on this system because you can not only type on it, you can label something, you can measure it, you can use arrows, and all of those things you can actually save to the image so that anybody else that pulls it up knows exactly what you were looking at, exactly what you're referencing, and the next time you take a picture, you can do that exact same measurement to know to the millimeter if anything has changed.
Yeah, it's great. It just sort of just copies forward and makes everything very, very easy.
Any other particular filters that you utilize, filters or functions?
So I think pigmented lesions. Is it nevus? Is it chirpy? So there's 3 LEDs within the Clarus. So you can actually do anterior retina and then posterior retina. So this way you can tell, oh, if it's a chirpy, it's at the level of the RPE. So it's going to come up with green and blue. Whereas if it's in the choroid, like a choroidal nevus, it's going to come up with the red LED. So that's always a great help. And I think especially in group practices, one time it's called a chirpy, one time it's called a nevus, one time it's called a choroidal retinal scar. This way really gets that sort of guesswork out of it.
Yeah, those filters I think have been used probably more than any feature on there because of that. And even our technicians, take a picture and maybe it's a new patient and they're coming out and they're like, oh, they have a nevus, and look, I checked it with the green filter, and all of this sort of thing. So, and it's very easy to toggle between those. It doesn't take any time. The system goes back and forth very swiftly and easily. You can do it on not only the camera. This is something that's unique to Clarus, because a lot of times you had to do those interpretations on the actual machine itself, not on a review station in a room. The Clarus, anything you can do on the camera, you can do in the room. So you can actually do those things in front of the patient or at your desk or whenever you're doing your review of the actual camera. But it's something that they take a color picture and then you can put those on later.
Yeah, right. So it's an indispensable tool, really, for any practitioner, whether you're managing a lot of disease or
Sure.
just a general practice where you see some disease. For diabetic patients, we're all seeing those, right? I mean, talk about useful with that, right?
Yep.
I mean, because it's very difficult to capture those, far peripheral hemorrhaging that you might see, and that changes your management, doesn't it?
A lot of the newer research is talking about a lot of these diseases which we thought were posterior pole diseases, AMD, diabetic retinopathy. A lot of that retinopathy is actually peripheral as well. In diabetics specifically, if you have mild NPDR within your posterior pole, but then you also have disease outside of posterior pole, that's a higher risk patient. So especially if the A1C is a little bit higher, the blood sugar is out of control, these patients, I'm going to see them maybe a little bit sooner, maybe 6 months instead of just 12 months. And that's also happening with AMD, where we're finding that if there's drusen within the macula, but there's also drusen outside the macula, like the periphery, we didn't really know what to do with that. But now that we're able to document that we're actually seeing changes, we're seeing that there's actually relationships where it's more severe disease if they have those peripheral findings, which a lot of times were just glossed over in the past.
Yeah, one area that we've noticed a big help with in our interpretations and everything is that we're not only noticing peripheral things that we didn't see, but sometimes even in posterior pole, if you've got a patient that's fighting you on your slit lamp exam, or they won't look where you want them to look, or they won't hold still, or they're squinting the entire time. This is a static image of that same area, so you can actually take the time to really examine every bit of that retina and not miss anything.
Yeah. How has FAF really changed, or changed? How does it change the way you manage maybe patients with macular degeneration? Typically, you kind of have a fundus image and you might do an OCT, but now that you have the capability of FAF, I mean, how does that change your treatment and management protocol?
Patients often come in because geographic atrophy, we don't really have a good treatment for it now. There's some things in trials that will hopefully slow it down or even stop it, but right now, I can't tell patients, look, take this medication, you get your vision back. So they always ask, am I going to go blind? Without autofluorescence, it's hard to say if the geographic atrophy is going to get bigger and bigger, is their vision going to get worse? And the OCT is just giving the structure. It's not really telling you anything qualitative about the actual tissue. Whereas with autofluorescence, if there's a hyperfluorescent ring around that hypo area, chances are it's going to get significantly worse compared to a patient where it's just hypo autofluorescence. So you have a better prognosis for patients, and either way, they like knowing something, some certainty, whereas otherwise, people tell me, I don't know.
Yeah, I think it's patient education is probably the biggest area because of the fact that we recommend the same things. Like you said, there hasn't been a lot of advancements in dry treatments yet. Hopefully some things are going to pan out down the line, but when you can really use that image to show a patient that they're at high risk for advancement, they're a lot more compliant with what you're telling them. So it's more about that conversation that you're having and being able to illustrate it, and know ahead of time that this may be a scenario that's not going to play out well.
Yeah, I think another area where it's helped me is chorioretinal scars. A lot of times we see these patients with these scars, we're like, oh, maybe it's old trauma, an old toxo scar, who knows what it is. I've actually started doing autofluorescence on these patients. If it's all hypo autofluorescent, I got nothing to worry about. Right. If it's hyper autofluorescent, then I really make sure I drill it into the patient. If you get any floaters, if your eye starts hurting you, if your vision goes down, let me know right away. And I see those patients back a little bit sooner. I actually had a patient, she had old scars sort of above her macula. We didn't know what it was. She's 18 years old, never really went to the eye doctor before. And she actually ended up reactivating. Ended up being just a toxo scar, reactivated and went into her fovea. She came in that day, and we actually were able to get her intravitreal therapy, which I would hope saved her vision, because if it goes into the fovea, that's really the worst prognosis.
I think it's the first time on an image that we've been able to differentiate between an active scenario and a non-active, whether it's a scar or AMD. I think a lot of times when we look at those scars, we think, oh, it's just a scar, right? Scar's safe, it's fine. But when you have those and you can point that out easily in an image, there's no invasive, injection or anything like that. It's pretty game changing.
I want to take just a second to talk about software. Sometimes that can be just as important, right, as hardware. It can be, even your phone, right? Doesn't necessarily have to be related to this, but in terms of the Clarus, I mean, how's the software compared to the hardware? No, the hardware is excellent, right? What about the software?
Very user-friendly. You can pretty much do anything you need to do on that image. You can save different versions of the picture. You can parse out the images that because one thing I guess we didn't really say is that when you get the 200 degrees, you take 2 pictures to do that, and then the camera merges those together. But you can parse those out and look at them individually, zoom in, change things. You've got, of course, the filters we mentioned. You can annotate, you can change brightness, you can rotate. You can really do just about anything you would want to do with this picture. It's a new system, so things are, of course, being updated, and ZEISS is working hard to do patches if there are any issues and really stay up to date with that. So I think it's just going to get better and better.
Yeah, I think one of the main sort of great things going on with Clarus is that it's made by ZEISS, which is a comprehensive ophthalmic company. So they make OCTs, they make visual fields, and they have their ZEISS Form software. So this does integrate into the Form software.
Yeah.
So when you have all that data all in one place, it just makes it much easier. And again, I'm all about efficiency when it comes to the office. So if I can have all my data all together, that just makes it much easier on me to make not only a decision, but just increases my workflow.
Yeah, so if you had to take a 1 minute just to talk about how it's changed the way you practice, or it's changed your practice, sounds like you would probably say efficiency, right? I mean, anything else? What's the take home?
I would say with the pathology documentation, because I'm a really big believer that a lot of this, especially far temporal periphery, pathology is going to become very, very important. And right now, we're not really sure what to think of it.
And it's hard to examine out there, isn't it? It
Yeah.
doesn't matter how good you are at indirect, right? It's very hard to get out there.
Yeah, especially in some patients. So as we get more and more information, I think that's going to be sort of the next frontier of our sort of prognosis for patients and how we think about these diseases.
Absolutely agree with you on the clinical care side. It's a more comprehensive approach to our patient. It's bettering the care that we can give. It's bettering the education that we can give, the knowledge base, the way that we're able to interpret lesions, interpret disease. From the other side, and the practice management side of it, I think it's really given us a tool to be able to get in touch with those millennials that will not go to the eye doctor because they have to be dilated, but we still have a tool that gives them, of course we're still educating on the importance of dilation and ocular health, but if that is truly a barrier to them even receiving care, we now have a tool that allows us to give them a comprehensive eye exam and be able to feel confident in the fact that we looked at their entire ocular health.
I think it'd also be a powerful kind of message your practice can send in terms of a marketing standpoint,
Absolutely.
right? We have this technology, because a lot of practices don't.
Yeah.
And, in this day and age, it's, a lot of consumers, patients are looking to go where the technology is.
Yeah, we were the first in our state to get it, and our staff were so excited. I've never seen them so excited for a product before, and they've embraced it, and they were talking it up to other patients that were in the practice before we even got it. So it's exciting.
Yeah, just one thing, piggyback on, patients don't want to get dilated. A lot of times, if you show them something like this, like, wow, there's that much back there, maybe I should get dilated. So next time, or maybe they'll even schedule the dilation that time.
Yep.
That's actually happened with a few of my patients that didn't want to get dilated. Just because they're the younger side, they're not used to being dilated, and they're like, why do I need it? I'm healthy. But this just shows them that there might be something going on there, because it's a lot more complicated than they think.
Absolutely.
So it's great for patient education, right?
100%.
Great for practice management, really great as a tool to increase your ability to diagnose and manage them.
Yeah, you could talk all day about disease, but if you show them a picture, I go, like, this is a normal picture, which I'm really big at. I have a normal saved on the desktop of my computer. I show them, this is a normal picture, look, and then I show them their picture, look at all this bleeding. That should not be there. Or look at this scar, it should not be there.
It's powerful,
this is why we
isn't
need
it?
to see you back,
Yeah, it's very powerful. I mean, if you show an image that's got a bunch of blood in the back of their eye, they don't feel that most of the time, unless it was from a trauma or something. It was diabetics, they don't know what's back there. They didn't know, anything's changing. And as soon as you show them that, their whole entire perspective changes on their whole health, not just their eyes.
Any final thoughts?
I really think it's a completely innovative and game-changing piece of equipment that we really needed in our space, and that a lot of practices are really going to fall in love with as soon as they get it.
So it's not just about the periphery, right? Even posterior pull, it's changed the game there too as
100%.
well.
Yeah, it's definitely completely different. Like, I'm sort of like a technology geek. I've always been into OCTs, the ultra-wide field photography, and this is really what ultra-wide field promised. It promised these high-quality images, it promised 200 degrees, and before it wasn't really that, but this really is it. That you don't need to have a standard fundus camera and an ultra-wide field camera. This is all done in one, and you don't have to look at different images. I don't have to look at my fundus camera for glaucoma and then look at a retinal tear on my ultra-wide field camera. This is all done in one, and makes it easier for me, easier for a patient, and of course, if it's just high quality, like what more can you ask for, right?
Yeah, I mean, we still have our standard camera, and it's literally just there now in case we've got 8 people that need a picture, and we can get theirs on that one. It's because the quality and the optics that are available on this camera far surpass what you're going to get on most standard photography anyway, so why wouldn't you use this for everything?
Most of our techs get much clearer images on the Clarus than they do with our standard fundus camera. Our standard fundus camera is there basically just for angiography now. It's really gone down a totem pole and amount of usage,
quickly.
Yeah. And, at some point, just rumblings, I guess, that this will have angiography, so we'll probably get rid of that completely.
Yeah, it'll be exciting to see where it goes.